Hi there, my name is Andrew Hazelton. I'm a paramedic in Central Texas, and this is a lecture I gave at the 2024 Austin Trauma and Critical Care Conference titled When Things Get Weird. That's my QR code for my link tree. That just takes you to a site where I keep all of my previous and any future lectures that I might have. So if you're finding this on YouTube or some other media platform, just go to that and that'll take you to anything that I've given lectures over. All of my lectures are copyright protected under what's known as the Creative Commons non-commercial license. That just means that it is free to distribute. You can pass this out, you can use it for education, do whatever you want. You just can't make money off it, and you have to cite the author, which is me. Otherwise, this is yours to have and learn from. Also, for transparency, I did use AI for the creation of this lecture. It basically involved data gathering and some info that I used for understanding more of the complex topics in pathophys that we're going to be talking about. So for full transparency, I left the ChatGPT research log QR code at the end of the page, or excuse me, at the end of the lecture. So if it's something you're interested in and you want to know how I did it or what information I got from it, it is freely available. Just doing that for AI transparency. And speaking of AI, if you're uncomfortable with that, I decided I was going to ask AI to create a haiku for EMS. And so it gave me that one, which I didn't think was that funny. It's kind of weird and deep, but I asked it to then make it funny, and it gave me that one. And I thought that one was great. So had a laugh. Okay. So for disclosures, I have none. I am not representing any department or agency or company. I am speaking on my behalf, so these are my opinions. Make sure to follow your own local protocols, or at least call before you do something that is out of your scope, and get somebody with a higher licensure on the branch with you. So as I said, this lecture was given in Austin, and that's where I'm from. This is where I live. And there is a saying that we have used for about the last 20 years, and that is keep Austin weird. And so along with this title, When Things Get Weird, let's talk about that statement, keep Austin weird. It actually was coined by this guy right here. His name is Red Wassenich, and he coined the phrase keep Austin weird. Back in the late 90s, he called into a local radio show who was asking for donations, and he was a well-known city activist and was well-known throughout the community. They asked him why he was donating money, and he said, "I want to keep Austin weird." So that motto kind of guided the city's kind of quirky side that Wassenich knew. He grew up in Austin. He was a librarian at Austin Community College for over 30 years. But Keep Austin Weird has kind of transformed into a commercial version. And that's not what Red Wassenich, I think, was talking about. He was talking about what made Austin weird. And Austin is a weird freaking town. I've been here for 16 years, and it is unlike nothing in the state of Texas. It exists on its own. But here's some of the things that I think kind of represent that vibrant, eclectic, weird history of Austin. We have so much cool, strange history. Up there at the left, the guy standing there with the pole, that is a gentleman known as Leslie Cochran, probably the most famous homeless person in Austin. He died a few years back, but he actually ran for mayor. And I know what you're thinking. Crazy people run, I'm not calling Leslie crazy, but let's call them eccentric people run for positions of government all the time. Yeah, except he got 7% of the vote. 7% of the voting population in Austin wanted him as our mayor. So it just kind of goes to show how strange our history is. And there's a lot of other things that made it unique and beautiful and just weird. And when Leslie died, a lot of people say that kind of Austin's weirdness died with him. And that's kind of true. We're a huge city now. We're the 11th largest city in the United States. And with that comes that growth and that tech boom that has been occurring for the last 20 some years. And Austin has struggled to keep its weirdness, but I think it's still there, and we're going to go find it. I've been working in the Austin area for the last 15 years, and I am here to tell you it is still weird. The medics I work with would also agree with you. So, in that essence, I think it would be fun if you and I were to run some calls at my truck or at my station with me on some calls. This is my station where I work. I work at Medic 8, A shift. It's an awesome station, awesome district, and we run lots of sick people. So in the essence of keeping things weird, we're gonna look at 3 different conditions that all start out pretty normal. These are all things that we run and we have extensive training on, but all these are gonna get weird. And in that weirdness is a specific condition that we're gonna learn about. We're gonna learn about the pathophys of each one, and we're gonna learn at best data on treating that. And that's what we're gonna do. And in return, we're gonna come up with a better framework for how to manage these patients. So our first call is gonna be at the historic Barton Springs Pool. Barton Springs Pool was founded in 1917 by Andrew Zilker when he purchased it from a gentleman known as William Barton. He named the springs after his daughters. And a lot of people don't know this, but there's actually 4 springs that kind of feed into the Barton Springs Pool. The largest one that is generally referred to as Barton Springs is actually called Panethea, which was the name of his first daughter. It stays a beautiful 68 to 70 degrees all year round, and it's one of the true treasures of Austin. But this is where we find us on our first call. This is for heart problems, and it's a 48-year-old male. He's having palpitations. He can't catch his breath. He woke this morning, went about through his normal routine. He noticed some shoulder and chest pain, but he determined it to be muscular and started on his normal swim workout. Kind of that view from the door, he's clearly sick. We see he has pale skin. Fire has got some vital signs for us. He's got a positive radial pulse. They listen to lung sounds, which are clear. He has a high blood pressure of 180/100 and a heart rate of 120. That also reflects that on our 4 lead with the sinus tach. So we're gonna do what we all do, which is grab a 12 lead, and we see that. And if the hair is standing up on the back of your neck right now, that tells me that you are good at identifying sick patient 12 leads. This is an anterior STEMI, and it usually results from occlusion of the LAD. Why are LAD occlusions so scary? Well, first off, I'll tell you that I generally don't see these patients, LAD patients, in the wild that are living. These are generally those patients that die from sudden cardiac arrest. Why is that? Well, LADs are a lot larger than RCAs, and they occlude a larger vessel, and a larger portion of the heart is infarcted. And this makes us very concerned because this has a very high mortality rate. 70% of these present with significant ventricular ectopy. So we're concerned, and we're already starting our STEMI activation, and we're kind of working on a movement plan on how to get this patient to our ambulance because we know this is a time-sensitive situation. And the patient's condition changes. He starts to snore, he postures with seizure-like activity, and then he goes into what we see here on the monitor. He is in a wide complex tach. The rate is 184. We have clearly defined an unstable wide complex tach, and we know what to do. We need to shock him. So we start doing all of our treatments. We start shocking him, and he eventually proceeds into cardiac arrest. So we're gonna give him epi, and we're also gonna give him amio. But the problem is, no matter what we do, he doesn't get out of VTAC. In fact, he progresses even more. He goes into polymorphic VTAC, then into fib, and we cannot get him out of fib. We continue to shock him. We continue to give him epi, and we max out on our amio, and we are left with nothing left to do. And we're wondering, why can't I convert this patient? Well, this patient is weird. This patient is experiencing an electrical storm. So what is an electrical storm? The basic definition of electrical storm are patients that are in sustained VTAC or VFib. But more importantly, electrical storm affects a lot of our ICD patients. So patients with internal cardiac defibrillators, this definition of electrical storm is 3 or more shocks in the last 24 hours. So to understand electrical storm, we need to do a quick deep dive to understand what exactly is going on at the patho level, because our treatment is going to be aimed towards that. If we're going to talk about electrical storm and the causes, I want you to remember these 2, the after depolarizations. When I heard that word, I kind of thought of the late 90s indie rock band. I assumed there was a name called the After Depolarizations because it sounded cool. I Googled it. There's no band name that I know of. So if you're looking at starting a band, there's a cool name. You can have that one for free as well, along with this lecture. But these are EADs and DADs. And what does that mean? Well, that stands for early or delayed after depolarization. And these occur on that critical part of the cardiac cell cycle known as phase 3. And that is where we enter to our repolarization. And fluctuations of the phase 3 by means of EAD and DADs changes the type of calcium or the way calcium flows out of the cell. And in phase 3, we are trying to get all that calcium out of the cell to depolarize. But in this case, it doesn't. They actually repolarize. And this is where our reperfusion or those VTAC or ventricular arrhythmias are occurring. So why is it occurring? What is going on? Well, there's a lot going on this slide here, but I want to break it down for you so we can understand essentially what is occurring on these electrical storms. When these patients are going into a wide complex TAC, they are having a dysfunction of something called their NCX. What is NCX? Well, that stands for sodium calcium exchanger. And that operates based on the electrochemical gradient of sodium and calcium across the cardiac cell membrane. When this starts to dysfunction, we start to have rises in calcium in that phase 3, and that is more susceptible to our reperfusions and VTAC. So when you think of this, think of disruption of the NCX. But how does the NCX get disrupted? Well, it does it in multiple ways. And the way to think of electrical storm is we're going to take patients and put them in two categories. We're going to put them in triggers or substrates. And if you see this picture here on the, they look like cell microscope pictures. This is actually called a Mofart stain. And Mofart stains these, and it actually allows us to look at the cardiac cell. And if you notice on the right, there's extensive kind of yellow fibrous tissue. Well, that is cardiac fibrosis. So that is what we know as ventricular remodeling. When that happens, all that yellow stuff, it affects the NCX and it makes it unable to operate. And the NCX exchange becomes overwhelmed, and large portions of the heart are susceptible to that phase 3 EAD. And that is what is causing these VTAC episodes. But if you look all the way over to A, under triggers, these are relatively healthy hearts. These are not hearts that have substrates. They don't have cardiac fibrosis. These are the people that we take care of that collapse on the treadmill, die during exertion. These are the runners that we resuscitate on marathons. So electrical storm affects both patients, both healthy and non-healthy. But kind of what I want you to take away from the slide is there are structurally normal hearts, which we're going to put them in triggers, and there's substrates that are cardiac heart disease. So we already said that substrates are involved with cardiac remodeling and heart disease. So the majority of our patients that we will see in electrical storm will actually be in this category. 30% or up to 30% of all ICD patients will actually experience an episode of electrical storm in their life. This will make up the majority of the patients that we will take care of in an electrical storm. One good thing is it is usually monomorphic. I guess I wouldn't say it's good, but it's just a finding. The majority of these patients are in a monomorphic VTAC. And we've already explained what's going on, but those substrates and that regrowth of that myocardial scarring creates these little re-entry pathways that you see there on the left-hand side, that little re-entry circuit. And this is what is causing these patients to go into VTAC. So we talked about sick hearts. Let's talk about the triggers or the structurally normal hearts. These are patients that are also going to be affected by the NCX, but they don't have cardiac remodeling. So what's going on here? Well, the NCX can be affected by things like ischemia and hypoxia. So when we think of things like large ischemic patients or large vessel occlusion, large LAD occlusions like our patient is experiencing, they can go into electrical storm because of the rapid dysfunction of that NCX. There's also other things that can trigger electrical storm in these patients. And these are those patients that have things like Brugada, prolonged QT syndrome, and a lot of other things to include electrolyte imbalances. And this can actually send them into VTAC. One interesting thing is most of the data shows that these patients will often present with polymorphic VTAC more often than the sick hearts or the patients with ICD. So what does our clinical presentation look like when we're coming up on these patients? Well, let's start with kind of the complaints. These are going to be those typical cardiac complaints that we often run on, right? We've already talked about LADs and ischemia. So these are often those ACS patients or those cardiac arrest patients. So we may find them in VFib or VTAC before we even get there. We've all probably been on that patient that is receiving shocks or repeating shocks from their ICD, and it's uncomfortable and they're anxious. And so we're responding to that. And also the patients in those triggered category, those people with QT prolongation, WPW, Brugada, those will be like palpitations and syncope. The history that we're concerned about are the ones down there in red. Patients with CAD, heart failure, ICD, and diabetes are way more prone to electrical storm. For clinical presentation of the ECG, we already talked about the majority of our electrical storm patients are actually going to be in monomorphic VTAC. That is because they are sick hearts, and those sick hearts with the ICD just generally stay or start in that monomorphic VTAC. So about 70 to 80% of these patients are just going to stay in that VTAC, wide complex TAC. A smaller group, preferably those triggered or well hearts or healthy hearts, tend to go into more polymorphic VTAC and VFib. And that's about 20 to 30%. So electrical storm's pretty intimidating and it's scary, but we got to come up with an easy conceptual framework for how we're going to take care of these patients. And I'm sure you're already seeing that age and history play a huge part in this. If I have a young, healthy person, I am probably not concerned about a chronic heart or substrates electrical storm unless they have a history of something. On the same token, if I'm dealing with an elderly patient with multiple cardiac issues, CAD, CHF, and they have an ICD, I am most likely going to lean towards the substrate. And so this is just a general way of how we're going to look at this. So before we embark on what I call irreversible course of action, this is a great time to pause and think about what we're doing. And I love this quote: when you hear hoofbeats, think horses, not zebras. What do I mean by that? Well, when we're thinking of our treatment, the first thing we need to ask after we've done our ABCs and we've determined stable or unstable, we really need to ask ourselves this again. Is this really VTAC? What do I mean by that? This looks a lot like VTAC. It's wide, it's fast. But if you look, it's not just wide, it's really, really wide. Like over 200 milliseconds wide. So when you see a really wide VTAC, I want you to think hyper K before we do anything else, because these patients do not respond well to amiodarone. We want to give something like calcium. So let's say we had this patient. Well, what if their K was 7.3? What if we just gave them an amp of calcium? What would happen? Well, this might happen, and we wouldn't even go down the electrical storm route. So I want you to remember, over 200 milliseconds, think tox and metabolic first before we go down to VTAC. So moving on, we've determined that this patient is in VTAC. So we've determined that this patient is in fact in VTAC, and we're going to put them into those two categories. It doesn't matter if they're stable or unstable, they receive, whether they're chronic or temporary, they're going to receive the same thing for unstable, and that is electricity. Taking care of an electrical storm is taking care of it with electricity first until we can ensure that we're providing the most amount of energy and alternative pathways to our patient. What does that mean? Well, these types of patients can be extremely hard to break out of VTAC. Why is that? I already said that the majority of these patients have extensive cardiac remodeling and they have giant hearts, and that left ventricle is giant and it needs more energy to break through, to depolarize that foci to get us out of VTAC. And the way we do that is by giving the max amount of energy and making sure we're doing what's called alternative pathways or vector change. So the reasons for this is we're going to give a higher total energy dose to optimize energy for the critical areas of the heart, and we're going to do vector change. So if we defibrillate alternative pathways or different vectors, these methods may overcome barriers to successfully defibrillate these patients. So if you're like me, I was diving into taking care of these patients, and you said, Andrew, these patients are in VTAC, but you also said most of them have ICDs. So can we shock that? How do we manage an ICD during this? We have a lot of things going on with this very sick patient, and I don't know how to manage that. Well, I'll be honest with you, I didn't know either. And so I sat out to do the research and see what I could find. And obviously, yes, we can shock somebody with an ICD. It is safe. Some literature recommends placing the pads 3 to 5 millimeters away from the device. Others say it doesn't matter. Either way, just do it. So make sure the pads are placed carefully and, if possible, away or not touching the device. But these patients can be defibrillated with external defibrillation, even though they have ICDs, and they need to be. Remember, their ICD is not doing the job in the first place, which is why they called us. So speaking of pacemakers and defibrillators, let's talk for a second about the magnet. What do I mean about the magnet? The magnet comes into talk a lot when we're talking about things like VTAC, electrical storm, and cardiac patients with ICD. These magnets have been used and are used to actually turn off the device, but we generally don't want to do that. And we need to assume that the ICD shocks are appropriate until proven otherwise, okay? So if we do place a magnet on, or we've determined that we need to do it, we also need to understand that turning the magnet off turns the ICD and as well as the what's known as anti-tachycardic pacing and goes into what's known as a magnet mode. Well, what's a magnet mode? Well, a magnet mode, so placing a magnet on there, will actually turn off the ICD, but if the patient also has a pacemaker, it will allow the pacemaker to continue, but go into a set rate of anywhere between 80 to 100 beats per minute. So that is what is known as magnet mode. But we want to not use that magnet if at all possible. We need to assume that the ICD shocks are appropriate. And more importantly, we want to not turn off something called ATP. What is ATP? Well, ATP is our friend. ATP is a protocol that the ICD and pacemakers have at terminating VTAC. And it's actually really successful in terminating VTAC, like 70% with the best data. So how does it do that? Well, a lot of the older medics might remember the term overdrive pacing. That's all this is. But this is happening simultaneously in the heart while we're trying to do our stuff. So putting on that magnet will generally turn off ATP, and it's very successful in terminating VTAC. But for the sake of this lecture, we have to assume that it's not working because we're there. So let's get into pharmacology. And there's a lot to unpack here, but I'm going to make it pretty simple. We give amiodarone, plain and simple. Why do we give amiodarone? Well, there's a couple reasons. One is it's a class 3 potassium channel blocker, and it affects that phase 3 of the cardiac cell cycle. So it's really good at addressing EADs and DADs that are occurring in that cell cycle. It also blocks beta, calcium, and sodium channels. But amio is not the only kid on the block. There's other things that we use for this. So let's talk about that. Procatamide. If there's any old medics in here, they're going to sigh and they're going to say, I remember procatamide. And what do we remember about procatamide? the drip being hard. At least that's what I did. Well, procainamide with the best data shows that it's actually better than amio for getting rid of VTAC. It almost is double the success rate as amio. So why don't we use it? Well, there's a couple reasons. The Procameo study, is the best data we have to look at this. And it showed that procainamide actually did convert VTAC faster than amio. And it was relatively safe. The problem is procainamide has concerns for being used in patients with cardiogenic shock or heart failure. They don't do as well when compared to amio. So that is one of the reasons why we shied away from moving towards leaning into procainamide. The other thing to consider, and this is just more of a large industry, just kind of how EMS works, is amio can be used on a lot of things, where procainamide is really good for VTAC, but maybe not so good for some other things that we might use amio for. So amio continues to be kind of our best drug that we give for addressing electrical storm. Lidocaine is also there. Lidocaine has shown in studies to be less effective than amio or procainamide, but it's still something that we often see and use. Not a lot of data to show that this actually breaks people from those deep cycles of VTAC like electrical storm. Magnesium's on there because I also wanted to mention that we can often give magnesium for torsades, and some of these patients are in polymorphic VTAC. It is safe to give for these patients. Just in the context of electrical storm, there's not a lot of data to show that magnesium actually affects the area that we're trying to address, which is that third cycle of the cardiac cell. So we can't talk about electrical storm without talking about the concept called sympathetic surge. And this is kind of where it gets weird. And this is what we need to understand, where we might have to augment our treatment for managing these patients. So what is sympathetic surge? Well, sympathetic surge is a catecholamine surge. It's also known as paroxysmal sympathetic hyperactivity. Let's say that 3 times together. Actually, let's not. But this is basically a rapid fight or flight response to the body when it's acutely ill or has been insulted. And it's fight or flight, so it has all of those symptoms that we know about, including increased heart rate. And this is known to affect cardiac arrhythmias. And it all comes down to what's happening right here in this nerve bundle. This is a stellate ganglion nerve bundle, and it runs from our brain down to our neck and into our heart. And it regulates a lot of the autonomic functions and affects heart electrical activity. So dysfunction or hyperactivity can lead to arrhythmias. And this is the main kind of focus or treatment that is placed towards treating people that are in these sympathetic surge electrical storms that we can't break out of VFib, VTAC, or torsades. So knowing that, it gets us into this uncomfortable area where we really have to ask ourselves, is it good to give epi to these patients? If I have a patient in persistent VFib, VTAC, and they are prolonged and not coming out of it, why are we giving them epi? If we are concerned about a sympathetic surge, is epi going to make that worse? So administering epi to cardiac arrest patients suspected of having electrical storm can worsen the situation by increasing that sympathetic activity. So great, what do we do? Well, a big side of treatment for sympathetic surge and electrical storm is actually the use of beta blockers. The use of beta blockers in treatment of ES is supported by multiple studies and clinical guidelines. These are the 2 that are generally used or talked about when you look at studies, esmolol and propranolol. There's no significant study that shows one or the other. Esmolol is generally preferred for acute management just because it has a short half-life and rapid onset. But using these are going to fight that sympathetic nervous system. It's going to slow things down, and that's what we're trying to do. So what data do we have to show that any of this works? Well, here's kind of the best data or observational studies that kind of guide us in the practice of that. The first study reviewed esmolol use in short-acting beta blockers in emergency settings, and it suggested that it was a feasible adjunct therapy for refractory VFib or electrical storms. The second study examined a combination of both esmolol vector changes as well as dose cap epi, meaning we just didn't give epi over and over again. We actually dose capped it. And it wasn't a great study. There wasn't a lot of patients, but it did find some potential benefits in this critical context. And there's no real good data to show that it improved outcomes, but there was some promising data that this helped treat ES. The other one is actually an observational study, but gave a really good deep dive into the dangers of giving epinephrine to a polymorphic VTAC patient, particularly young ones. So this is actually regarding pediatric patients. So emphasizing that epi in these patients may not be useful, especially in kids. So along with electrical storm and sympathetic blockade, we can also address analgesia and sedation considerations. This is also going to attack or treat that stellate ganglion that might be overactive. So we need to give some sort of sedation or analgesia. And that's usually done with these three right here. And we kind of start at the top with more of a light sedation, which is midazolam. Although it's a GABA receptor med, it still provides light sedation. We have some analgesia, which is fentanyl. But what we're really trying to do is more of a deeper sedation, and that's usually done with drugs like propofol. But these are all things that we might apply to these patients in electrical storm. You see I have ketamine up there as caution. I love ketamine. I think it has so many versatile roles in pre-hospital medicine, but it may not be good for this type of patient. Why is that? Well, we know that ketamine is a sympathomimetic, and it has properties that are probably going to aggravate or stimulate sympathetic surge. And so there's some caution, but understand there's no studies to show this. This is just theoretical and caution. So I say that because a lot of our patients in VTAC are going to be unstable. And ketamine is kind of that drug that we reach for because it tends to save or preserve the patient's perfusion status. But we have to be careful with regards to electrical storm because it may actually re-aggravate the sympathetic surge. So for hospital treatment, they continue to sedate, shock, but also they're going to do more invasive treatment. So this is called a stellate ganglion block, or SGB, and they use ultrasound or CT, and they actually numb the ganglion at the C6 and C7 vertebrae. So they actually numb it. They'll use something like lidocaine, and they'll actually numb it to hopefully turn off that sympathetic surge. And like I said, electrical storm is very, very complex, and treatment gets advanced very quick. So these patients are going to be treated by us for the first 10 to 30 minutes, but their treatment in the hospital gets very extensive, and it kind of looks like this. There might be some ICD reprogramming if there was a problem, or if their pacemaker was not addressing the issue. So maybe they're increasing the energy or changing the way that it interprets VTAC. Ablations are often used for those healthier hearts that might have some sort of trigger. We already talked about sedation and then continued anti-dysrhythmic drugs. Some other bailout therapies are also LVAD and ECMO. So again, very, very sick patients. So what happened to our patient? Well, the crew recognized this was an electrical storm. We were doing the normal PIC crew. He received single as well as dual sequential defibrillation. He got some amio, but he was going in and out of arrest. He was going in between sinus TAC, VTAC, and polymorphic VTAC. Our crew decided to withhold further epi, called for guidance on what to do. They agreed that epi should be withheld, and we ended up getting ROSC. He was further sedated in transport with 5 of Versed and 100 of fentanyl, which is blood pressure supported. They also started an amio drip just because of the reoccurring ectopy and VT that was going on, and he was transferred to the cath lab, and further sedation was done with propofol. And there is his beautiful post-cath 12 lead that looks way better than the LED that he had before. Thank you to Dr. Smith, ECG blog, for that. So what's our bottom line? Well, electrical storm is a small but important subgroup. We need to be really well versed in how to take care of the ICD type patients that need treatment for electrical storm. Sympathetic surge is a real issue, and we need to have strategies on how to manage that in the field. Some of that involves augmenting our medicine, preferably epi, and maybe giving things such as Versed, fentanyl, or propofol to sedate them, as well as beta blockers. So moving right along, let's go to our second call. This is going to be a priority 2 seizure. Now, a crew has already been on scene. This patient has been seizing for a prolonged time, and they actually requested us for a PL6 backup because they thought this patient was an RSI candidate. This patient is located outside the Cathedral of Junk in Austin. So what is the Cathedral of Junk? Well, it's just that. It's a giant cathedral of junk that is multi-storied, and it's a structure built entirely by a local artist in his backyard, and it offers visitors a unique and whimsical exploration of creativity and repurposed materials. Very, very Austin. This kind of showcases what I think is the essence of Austin and keeping Austin weird. It's just really cool. But today we're having a seizure out here, so we need to take care of this patient. So let's dive in. This is a 26-year-old male. He does have history of epileptic seizures. He was diagnosed as a kid in his teenage years. His only recent history is some recent GI issues. He's been vomiting and not really keeping anything down. He does take Keppra. We don't know about compliance. He's in the middle of traveling, and we don't even know if it's on board or if he's taking it. We do know that the seizure has been lasting for almost 10 minutes now. It took the first crew about 6 to 8 minutes to get on scene. This patient is continuing to seize, and we are now on scene. So we are well over the 10-minute threshold. Treatment prior to our arrival, the initial crew came on. We took care of his breathing and ABCs and all that stuff. They administered 5 milligrams of intranasal Versed. They've done that 2 times, but the seizure continues. And now we're here taking care of him. So what is status seizure? Well, first off, seizures affect a large amount of the population, roughly 11% of us. 1.2% of the total population actually has epilepsy. That equates to about 3 million people, or over 500,000 children have epilepsy. So this is widespread in our population. Some further stuff about status seizures. When we talk about this refractory seizure, these are kind of the time limits that we're looking for. We have that basic seizure. We kind of start thinking of status epilepticus after about 5 minutes, but when we're really into that start to 1 hour, that's usually that refractory status epilepticus. We can get further into what's called super refractory status seizure, which is greater than 24 hours. These have extremely high mortality rates. I have the first 3 sections in red because I think this is what we're going to focus on, because this is where EMS is crucial at taking care of these patients, is in that onset to 1 hour. So if we're going to learn about status seizures, we have to learn about some patho. And I think we need to talk about the usual suspects that pop up when we are having a seizure. And they're kind of these 4 that I like to pick, because these are what our medications are going to affect. We have the synapse. The synapse is that junction where the neurotransmitters are released. Its effective treatment aims to decreasing the activity of that neuron. GABA receptors are the primary inhibitory neurotransmitter, and we're going to talk about response to GABA a lot. Also glutamate, that's the primary excitatory neurotransmitter. During seizures, there is excessive glutamate activity, so we have to control that to prevent status seizure. And then there's MNDA. MNDA is a receptor that responds to a type of glutamate receptor that play a crucial role in the synaptic plasticity. In status seizure, this receptor, or think of it as like an antagonist, can be used to block those receptors, thereby reducing the excitatory neurotransmission and kind of help terminate the seizures. So these are the usual suspects in the pathophys that we're trying to address that are causing the status seizure. So causes, there's a lot of them. And I don't like busy PowerPoint slides, but I left this one up here just to emphasize and drive home the point that a lot of the status seizure patients we take care of may not be epilepsy. There are many things that can cause people to seize. So we can't just focus in on epilepsy or non-epilepsy. We have to look at all the other reasons. And this study used vitamin D, which is a pretty good thing to think about. So all of these reasons are things we have to rule in or out when we're managing these patients. So what is our current best practices right now for managing? Well, first we're going to do ABCs, right? And also don't forget that blood sugar, especially repeat blood sugars on these patients that are going to be seizing for prolonged periods of time. But we have clear data to show that our first line agent should always be benzos. So benzos have the mechanism of action of affecting those GABA receptors. We already talked about GABA receptors being important at kind of working to turn off seizures. And so that little ion channel that you see there is affected by benzos that will wrap around or attach to the GABA receptors. And so this is, the studies show that this is the drug that ultimately is the best first-line drug for treating seizures. How do we know that? Well, we have a lot of good studies to show that. Long time ago, in 2001, there was a study that compared lorazepam to diazepam in placebo, and it found that lorazepam was better than diazepam for treating seizures. And what that did is it allowed us to kind of decide that lorazepam was better. Well, we don't have lorazepam, or didn't have lorazepam at the time. We only had diazepam. A big problem with diazepam in seizures is it has to be given IV. Lorazepam can be given IM. And so this kind of got us to start thinking of using midazolam more. Come full circle, about a decade later, the Rampart study was done. The Rampart study is probably the best, cleanest data we have to show what helps seizures. This was a double-blind, randomized clinical trial that looked at midazolam versus IV lorazepam over placebo. And it found that overwhelming IM midazolam was better than IV lorazepam. They're both benzos, but IM was more affected. And so the current best practices are these dosages, is to be very aggressive with Versed. And starting off right out the bat, we need to start off with 10 milligrams, which is for patients over 40, or 5 for under. And that's the best practice right now. So how well do we practice that? There's actually a study done 2 years ago that actually looked at how well we follow the best practices for treating seizures in the field. And it was pretty surprising. Almost over 80% of EMS treated these patients with midazolam. Great, we already know that's good. However, look at the mean dose. It was 4 milligrams. So we're underdosing these patients. More importantly, only 34% were treated with IM. So a large amount of patients were most likely delayed by trying to get an IV, or they were treating intranasal. We know that both of those are not the best course of treatment for immediate cessation of seizures. It's IM. Another data to kind of, another study to kind of drive this home is this study looked at the association of time to treat with short-term outcomes for pediatric patients with refractory seizures. And it found that patients that seized greater than 10 minutes died more frequently and had longer convulsive episodes during their seizure duration. Another little thing that it noticed is that these delays were more delayed in the pre-hospital group when compared to the in-hospital group. That means that a patient having a seizure in the hospital got the medication faster than they did with EMS. And if we look at the study before that, we can see that a lot of the times it was delayed for things like the wrong route or trying to get an IV. And so we want to make sure that we're going IM with these patients. So pre-hospital airway considerations for status seizures is not well defined. This is a big gray area. So we're going to try and just break this down into what would be the best course of treatment for these patients, or consensus on how to manage that. Well, first and foremost, seizure patients can go a long time before they need ventilations, especially the younger ones. So we have some data that kind of looks at how to manage these patients. First and foremost, these first 10 to 20 minutes are generally managed with BLS. That's a non-rebreather and NPA. We really want to watch things like pulse ox if we can. So maybe an actual disposable pulse ox, because if they are actively seizing, it may be difficult to get a pulse ox. But we can watch capno. So we can watch things for hypoxia and rising of capno. And when we do move down that course of action and get more invasive, we have to understand that RSIing these patients does not keep them from seizing. It just makes them not seize. Their brain is still seizing. So why is that important to know? Well, if these patients are RSI'd, if they have had prolonged downtime for seizures, they might be very not only hypoxic but acidic. And we need to make sure that we're meeting the minute volume on things like BVM or ventilator if we're going to manage these patients in an RSI scenario. But what I want you to take away from this is not I need to RSI these people. It's actually the opposite. Here's the best studies that we have. And I talked about Rampart being a great study. Well, these are secondary studies that retroactively went back and looked at data from Rampart and saw if there was more data that they can pull. And they did. And it kind of gave us a little bit of guiding data on how to manage patients. So both of these studies looked at Rampart patients that were brought in that were still seizing, and they looked at how frequently they were intubated. So the intubation rates were 21% for one and 7% for the other. So there was quite some inconsistency with that. But the big thing that they took away is that most of these patients that did need intubation kind of made up a population that looked like this. They were patients over the age of 50. They were still seizing. On-scene heart rates were greater than 120. They had decreased level of consciousness. But more importantly, the patients that had seizures from things like CNS tumors or strokes had higher rates of intubations. There was also a correlation with higher mortality in intubated patients. 7% of patients that were having status seizures died versus 0.5% that were not intubated. That does not say that intubation kills people. Sicker seizure patients get intubated and those patients die. So this isn't great data, but it just kind of helps guide us in our considerations for airway management. So second-line drugs. Second-line drugs are very effective from treating status seizures. These drugs generally can break seizures with best data about 60% of the time. So they work pretty well, but these are generally out of the reach of pre-hospital EMS or pre-hospital medicine. Well, why is that? Well, these drugs are kind of a one-trick pony. They work really good for one thing, and that's what you see here, stopping the seizures. These generally, they all do different things individually, but generally speaking, they affect that synapse or those influx of sodium channels in the synapse, and it helps stop the seizures. But the reason EMS doesn't generally carry this is not only are some of them expensive, but they're for they're for seizures. EMS has limited pharmacy, and so we generally like medications that we can use that are multinodal, I guess would be the way to say it. And so we don't see a lot of these. Keppra is carried a lot, sometimes on flight services, and some critical care services may have it, but that's generally not what we see. But these are often called second-line drugs. They're very effective, but not often found in EMS. So what if we gave ketamine to these patients? We love giving ketamine. EMS loves ketamine. The hospitals don't like it, but we like it. So can we give ketamine to seizures? Or why would we even think about giving ketamine to seizures? Well, ketamine actually does something really good. It blocks NMDA, and we already talked about that being a part of stopping the seizure cycle. So ketamine is a good NMDA receptor antagonist. And if we can antagonize that, we can hopefully stop the seizure. Is there any data to support that? Yes, there is. There has been plenty of data to show that ketamine helps stop seizures. Some of this data is, none of this data is done in a pre-hospital. None of these are RCTs. These are more just observational studies. But ketamine was shown to be successful, particularly in kids. One study noted a 73% reduction in kids treated with ketamine. Here's the problem with this data. Ketamine is not seen as a second-line drug. And so often this data that we have from 5 or 10 years ago is more in the ICU, neuro-ICU types of patients who have been seizing for upwards of 12 to 24 hours. And so while there's data to show it works, we don't know how we incorporate this into pre-hospital. This is a protocol made by CPRIC probably 5 or 10 years ago, but I thought this kind of summarized what a implementation of ketamine might look like in EMS. And this is called the rapid sequence termination protocol. And so you can see where we max out on our midazolam and we immediately go to our second line drug, which is ketamine. And so this is just kind of maybe give some sort of explanation of how we would apply it into these patients. So what happened to our patient? Well, we showed up. We already noticed that we knew that they gave 10 milligrams of intranasal. We just went ahead and gave 10 more milligrams IM, left leg. We continued to support ABCs. We monitored their ETCO2. We gave them oxygen by cannula. We actually placed an MPA. Patient maintained good SATs and CO2 was fairly normal. We called and got additional dosages for another 10 of Versed, and the patient continues to seize. We called for online orders of ketamine, a dissociative dose of 2 milligrams per kilogram, put him at 200, and the seizure actually terminated. He was monitored en route for apnea, did not have a lot of it, did not have to bag him, and he was transported to the ED where he was eventually worked up in the neuro and then was released with a new medication for seizures. So what's the bottom line on status seizures? Well, status seizures are life threats, make no mistake. EMS has an early but vital role, and that is breaking the seizure as fast as possible. The sooner we break the seizure, the easier it is to break. The longer it goes, the harder it is to break. So EMS has an early but vital role in this. First drug, best drug. That is 10 milligrams, Versed IM, or 5 milligrams if they're under 40. Ketamine does have a role in treatment of status seizure, but we have yet to see it implement fully into the field. So more studies need to be done to look at ketamine's further role in stopping seizures. So let's go to our last call. We've cleared off that one, and now we're going to a priority 1 cardiac arrest. And this is located at Eeyore's birthday party. And if you're not from Austin, you're probably asking yourself, what in the heck is Eeyore's birthday party? Well, I'm glad you asked. Eeyore's birthday party is an annual event in Austin, Texas. It began in the 60s as a spring picnic for students of UT, and they named it after the gloomy donkey character, Winnie the Pooh. Strangely enough, the date of Eeyore's party does not actually fall on the donkey's fictitious birth date. Someone knows that and called it out on my research. But this event is fun. It's live music, lots of interesting costumes, games, a variety of food and drink vendors, and it's just a whimsical, free-spirited, and weird atmosphere. And that's where we find our patient in cardiac arrest. So this is a 69-year-old male with a witnessed arrest. Our special event medics are already there. They've set up pit crew. They've applied the AED. He's already received 1 shock from the AED. Our fire partners are now on scene, and we have a good public arrest going. Everything is kind of rolling the way it should. But things are going to get weird. We put our patient on the monitor, and at our next rhythm check, we notice a nice coarse fib. So we're going to charge, and as they come off the chest, we go to shock, but something happens. One of the fire department says, whoa, whoa, whoa. And we notice the patient begins to kick his hands and legs. His eyes are opening, and he's looking around. We assume we just got ROSC, but we look on the monitor, and we still see fib. We can't figure out what to do. Do we shock this patient? Do we not? He's awake now, but I see fib on the monitor. Well, as we're spending that time trying to figure this out, he progresses back into unconsciousness, and we continue CPR. What just happened? I want to introduce you to the weird condition known as CPR-induced consciousness, also known as CPRIC. What is CPRIC? Well, CPRIC is consciousness during CPR. It involves things like eye-opening to grabbing the medics or even talking to us. But this is despite having no clear return of spontaneous circulation. And it's not a well-known phenomenon. Only about 50% of us actually know about it. This study just looked at an observation awareness of if we even knew what CPR-induced consciousness was. And this was a study from the UK medics. And it found that only 50 of them knew about it. Out of the 50, the majority of those people only learned about it because they had a call and it happened to them at that time. So not a good time to learn about CPRIC. So we're going to do that right now. So why are we having increased CPRICs? There's some studies that show that CPR-induced consciousness is steadily on the rise, and it's something that's kind of a newer problem for us. Well, why is that? Well, there's a couple theories, and none of these have been proven, but some of the theories are we have more people that are CPR certified. Things like the Take 10 campaign or the hands-only CPR has allowed these patients to get CPR really quick after dropping. So that's one of the things. The other thing are the other things you see on here, which are mechanical compression devices. These also have been associated with the need for addressing CPR-induced consciousness. So these things altogether are some of the things that we think is causing this to be more of a problem. So what are some clinical features of CPR-induced consciousness? Well, most of it is just body movement, particularly the legs. A third of them actually talk and make noise. Spontaneous eye opening and jaw tone are some other clinical features. The thing to remember is these patients are really fresh cardiac arrest patients, and they are associated with increased odds of survival. So it's important that we provide them the best care, and that's the issue with this, is it can interfere with that. This study looked at that. It looked at CPRIC and what type of havoc it caused to the resuscitation process. And this is the data that they found. About a third of it actually interfered with our CPR. More importantly, 75% had to have things like medication or physical restraint when they were dealing with this. And the study also found that mechanical compression devices were used in up to 80% of these cases. So we actually have a video of CPRIC in the wild. And I want you to watch this video because it's great. It actually shows real life CPRIC. You see a resuscitation crew who is resuscitating an elderly gentleman. And you're going to notice the clinician in the left is about to do point of care ultrasound to confirm ventricular standstill for cardiac arrest. So they are going to actually, you're going to see the heart come up on that screen and the heart is not going to be moving, but you will see the patient kick. The patient also in this video was noted to be pointing at the ET tube and fluttering his eyes. So let's take a look. Pretty cool, huh? So that's what CPRIC looks like, or can look like. But I hope you appreciated the confusion that was happening there. There was, you see the clinician starting compressions, but then he looks down and sees the legs moving and he stops and he's there. You can hear them. Do we have a pulse? Do we don't have a pulse? This is the issue with CPRIC, and I think this video really drove the point home on what it looks like. So why is this a big deal? Well, we already know that it's both clinical and ethical. It interferes with patient care. Clinically, we can't take care of these patients right. It's also very disruptive, particularly to our first responders. I've had the privilege of actually running one of these calls, and I can tell you it's very disconcerting to first responders who have never heard of this. It's also very stressful for bystanders and family. But most importantly, it's ethical. This study called the awareness study, looked at people who had memories, perceptions that were suggestive of consciousness during when they were resuscitated. And this data was only from in-hospital cardiac arrest, but it found that the patients that were successfully resuscitated from cardiac arrest, almost 40% of them had memories of this. More interesting, a study looked at cardiac arrest survivors who were discharged with favorable neurological outcomes over an 8-year period and found that up to a third of them actually fulfilled criteria for PTSD with symptoms that they experienced during their resuscitation. And this lecture is called When Things Get Weird. And so I want to get weird with you guys for a second. When I was studying CPR-induced consciousness, it kind of got me down this rabbit hole of when do we actually stop hearing or sensing things? And there was a really cool study done a couple years ago, and it actually looked at dying brains and if they could still register tones. So they had, I believe, 11 hospice patients that agreed to do this, and after they were clinically dead, they played a set of tones and they were hooked up to an EEG where they could read. And they found that yes, the brain was still registering tones even after the patient was dead. So this answers the question, they can hear you. Watch what you say on scene. This observational study just went out and combed to look for the best evidence, or with lack of evidence, what the world was doing when it came to pre-hospital treatment of CPRIC. And this wasn't a research study, it just looked at guidelines all over the world. And it found there were 23 known pre-hospital protocols for CPRIC guidelines, and there was one what's known as a good practice statement from ILCOR. We'll talk about that in a second. But you can see treatment was all over the map. Not only were the drugs that the clinician attempted to or gave was all over the map, spread out between midazolam, ketamine, and fentanyl. Morphine was also on there as well, but dosages were all over the place, particularly ketamine, between 10 and 200 milligrams. So there's nothing to really follow. Everything's all over the map when it comes to taking care of these patients. So what do we have to kind of guard our treatment? Well, as I said, ILCOR created a best practice statement, and it used what's called Delphi methodology, which it just looks for a consensus of over 70% of data to kind of guide how you should take care of these patients. And ILCOR put patients into two categories, interfering or non-interfering. Regardless of that, the standard of care was generally a sedative, particularly ketamine. Interestingly enough, the Nebraska EMS medical protocols introduced a CPRIC protocol after they started using Lucas devices and found that this was a reoccurring problem, that patients were having CPRIC when they were being resuscitated. So their best practice is to give a large dose of ketamine, 2 to 3 milligrams per kilogram IM, and then there's an IV dose as well. But these are large dissociative dosages, and these are the best course of treatment for sedating these patients and putting them basically in the K-hole so they lack memory and don't suffer when we're trying to take care of them. So what about our patient? Well, our crew recognized that this was most likely CPRIC. They announced it to our first responders so everyone got on board. They continued the resuscitation. They called for orders and administered ketamine. They gave him 3 milligrams per kilogram, or 270 milligrams IM. The resus was continued. Patient had no more purposeful movement. Unfortunately, the code was resuscitated in the ED. We ended up transporting due to a field termination because of it being so public. So what's the bottom line to take away from CPRIC? Well, we need to add CPRIC to our clinical framework. We need to understand what it is, and we need to have a plan for when it happens to us. The current best guidance on taking care of this is ketamine, IM 2 to 3 milligrams per kilogram, and there's limited data on this. So we need more RCT studies, because I think this is a great protocol to invest in, because it's taking care of our patients' needs when they're at the most likely the final stages of their life. We need to be nice to them. Thanks for getting weird with me, guys. I appreciate you taking the time to watch this lecture. If you enjoyed it and you want to share it, use that QR code. And there'll be some references after for you to look at. But thanks a lot, and I hope you have a good day.